Euthanasia is the practice of intentionally ending a life to relieve pain and suffering. The term itself comes from the Greek words eu, meaning good, and thanatos, meaning death, so it literally means good death. This act is one of the most profound and difficult topics in modern ethics. It forces us to confront our deepest beliefs about life, suffering, and the limits of our control over our own existence. When a person is facing a terminal illness with no hope of recovery and enduring unbearable pain, the question arises: is it more compassionate to prolong their suffering or to provide a peaceful end? This question does not have a simple answer and is debated intensely across societies. We can distinguish between several types of euthanasia, each with different ethical implications. The most important distinction is between voluntary, non-voluntary, and involuntary euthanasia. Voluntary euthanasia occurs when a competent person makes a clear and informed request to end their life. Non-voluntary euthanasia happens when a person is unable to give consent, perhaps because they are in a coma or are an infant, and the decision is made by someone else on their behalf. Involuntary euthanasia, which is widely condemned as murder, is when a person who could consent is killed against their will. These distinctions are crucial for any meaningful discussion about the morality of ending a life. Another key distinction is between active and passive euthanasia. Active euthanasia involves a deliberate action taken to end a life, such as administering a lethal injection. This is a direct intervention to cause death. In contrast, passive euthanasia involves withholding or withdrawing life-sustaining treatment, like turning off a ventilator or stopping artificial feeding, thereby allowing the person to die from their underlying condition. While some see a significant moral difference between killing and letting die, others argue that in the context of end-of-life care, the intention and the outcome, the relief of suffering, are what truly matter. The debate often centers on whether there is a genuine ethical line between an act and an omission. Finally, we have the concept of physician-assisted suicide, which is closely related but distinct from euthanasia. In this scenario, a doctor provides a patient with the means to end their own life, but the patient must perform the final act themselves, for example, by taking a prescribed lethal dose of medication. This puts the ultimate control in the hands of the patient. The core idea is to support the patient's autonomy without the physician directly causing the death. This practice, sometimes called medical assistance in dying, raises its own set of ethical questions about the role of doctors, who are traditionally sworn to preserve life, not to facilitate its end. The arguments in favor of legalizing euthanasia are rooted in principles of compassion and individual freedom. The primary argument is based on autonomy, the right of individuals to make decisions about their own lives and bodies. Proponents argue that if a person is of sound mind and facing a future of relentless, incurable suffering, they should have the right to choose the timing and manner of their death. This is seen as the ultimate expression of self-determination. Compassion is another powerful motivator. It seems cruel to force someone to endure weeks or months of agony when a peaceful alternative is available. Medical futility also plays a role, where continuing treatment offers no benefit and only prolongs the dying process, causing further distress. Beyond individual suffering, supporters also point to the significant emotional and financial burdens that a prolonged dying process can place on families and healthcare systems. Caring for a terminally ill loved one can be emotionally devastating and financially ruinous for families, depleting resources that could be used for other purposes. From a societal perspective, allocating vast medical resources to keep someone alive in a state of irreversible decline and immense suffering can be questioned, especially when those resources are scarce. This argument is not about devaluing a person's life, but about making rational and compassionate choices in the face of inevitable death and limited resources. On the other side of the debate, opponents of euthanasia raise profound moral and practical objections. The most fundamental argument is the sanctity of life, a principle often rooted in religious or philosophical beliefs that life is a sacred gift that should not be intentionally ended by humans. This view holds that all life has intrinsic value, regardless of its quality or level of suffering. Proponents of this view believe that we have a duty to preserve life until its natural end. They argue that accepting euthanasia undermines a foundational respect for human life and sets a dangerous precedent for society. Opponents also warn of a slippery slope, fearing that legalizing euthanasia for a narrow set of circumstances could gradually lead to its expansion to less severe cases, putting vulnerable populations at risk. They worry that people who are elderly, disabled, or depressed might feel pressured to choose death to avoid being a burden on their families or society. Furthermore, they emphasize the importance of alternatives like palliative care, which focuses on managing pain and improving quality of life for the terminally ill. They argue that with high-quality palliative and hospice care, the desire for euthanasia would be greatly reduced, as most suffering can be effectively managed without resorting to ending a life. The legal landscape surrounding euthanasia and physician-assisted suicide varies dramatically around the world, reflecting deep cultural and ethical divisions. Countries like the Netherlands, Belgium, Luxembourg, and Canada have legalized both active euthanasia and assisted suicide under strict conditions. Switzerland allows assisted suicide but not active euthanasia, famously permitting organizations that assist foreigners in ending their lives. In the United States, several states, including Oregon, Washington, and California, have legalized medical assistance in dying. In stark contrast, the practice remains illegal in most other parts of the world, often classified as manslaughter or murder, highlighting the lack of global consensus on this issue. Major world religions also hold diverse views, largely opposing the practice. Christianity and Islam generally teach that life is a gift from God, and only God has the authority to end it. They emphasize the sanctity of life and see suffering as a test of faith that can have spiritual meaning. While they strongly support palliative care to alleviate pain, they draw a firm line at intentionally hastening death. Hinduism also views ending one's life as a violation of religious principles, disrupting the cycle of karma and rebirth. Buddhism, while emphasizing compassion, generally discourages suicide, though some interpretations might be more lenient depending on the individual's state of mind and motivation. Philosophical ethics provides different frameworks for analyzing this complex issue. Utilitarianism, a theory famously associated with thinkers like Jeremy Bentham and myself, judges actions based on their consequences. A utilitarian would weigh the total amount of suffering caused by prolonging a life against the suffering caused by ending it. If ending a life leads to the greatest good for the greatest number by eliminating immense pain, a utilitarian might support it. In contrast, deontology, associated with Immanuel Kant, focuses on moral duties and rules. A deontologist might argue that there is a universal moral rule against killing, making euthanasia wrong regardless of the compassionate intentions or positive outcomes. Virtue ethics, which traces back to Aristotle, shifts the focus from actions or consequences to the character of the moral agent. It asks what a virtuous person, someone who is compassionate, just, and courageous, would do in a given situation. This approach doesn't provide a clear-cut answer but encourages a holistic consideration of the patient's suffering, the family's distress, and the doctor's role. It also highlights the importance of patient rights and autonomy within modern bioethics. The right of a patient to refuse medical treatment is a well-established principle, and for many, the right to choose euthanasia is a logical extension of this autonomy in end-of-life decisions. The debate over euthanasia becomes even more challenging when we consider the ethical gray areas where clear principles are difficult to apply. One of the most difficult issues involves patients with dementia or other conditions that impair their cognitive abilities. Can a person make an advance directive requesting euthanasia for a future time when they are no longer competent? If so, should that directive be honored even if the future incompetent person appears to be content? This pits a person's past autonomous wishes against their present state of being, raising profound questions about personal identity and the nature of consent over time. Another deeply troubling area concerns children. The Netherlands is one of the few places that allows euthanasia for children under extreme circumstances, but this practice is highly controversial. It is incredibly difficult to assess the level of suffering in a child who may not be able to articulate their experience fully. Determining whether a child can truly give informed consent or whether a parent's decision is in the child's best interest is fraught with emotional and ethical peril. Cultural differences further complicate the matter, as what is considered a compassionate act in one culture may be viewed as an unacceptable transgression in another, making universal standards nearly impossible to establish. These complex cases underscore the reality that the ethics of euthanasia are not black and white. There are no easy answers, and rigid rules often fail to address the nuances of individual human suffering. The conversation is not just a theoretical exercise, it has real-world consequences for individuals and their families who are facing the most difficult moments of their lives. It involves a delicate balance between deeply held values, the value of life itself, the desire to alleviate suffering, the right to self-determination, and the duty to protect the vulnerable from harm. In conclusion, navigating the moral maze of euthanasia requires more than just logical arguments or legal statutes. It demands profound empathy and a willingness to engage in respectful dialogue. We must listen carefully to the arguments on all sides, from those who advocate for the right to a peaceful death to those who champion the sanctity of every moment of life. As societies continue to grapple with advances in medical technology that can prolong life, these questions will only become more pressing. The path forward lies not in finding a single, universally accepted answer, but in fostering a culture of open, honest, and compassionate debate that respects the diverse values and perspectives involved.